Moving on to the next session, that's Compassionate Medicine, Exploring the Patient and the Physician Interface. May I call upon Dr. Nalaini Jagadeshan to chair and conduct the next session.
Good afternoon, all of you. And so we have come to an interesting session on compassionate medicine, exploring the patient and the physician interface. I would like to invite all three speakers to the stage, please. Prof Arosha Dissanayake, Dr. Ganaka Senaratne, and Mr. Lal Medawattegedara. As here we have three speakers, they will be talking on their perspective on compassionate medicine. First of all, I would like to call Mr. Lal Medawattegedara. He is the senior lecturer in English language, Open University of Sri Lanka. I would like to start with a famous saying by Sir William Osler. The good physician treats the disease. The great physician treats the patient who has the disease. So let's listen whether we have been a good physician or a great physician. So it's over to you, Mr. Lal, to talk about the experiences as a patient and as a carer.
Okay, thank you very much. Thank you very much. More than happy to share my experiential evidence as a patient and caregiver with this audience. Okay, I think I will start with one of my experiences, my personal experiences. I some time ago, about 10 years ago, I had a recurring skin rash. That is my layman's term for you know the medical term better than me. So this I asked around and consulted this famous doctor who is supposed to be very good at treating this condition. And I remember going to this private hospital and taking an appointment, and I was asked. My appointment was at 4:30 in the morning. So I walked to hospital at 4 o'clock and then had to wait for like 45 minutes for the doctor to come. During which time I read a book. I mean, I carry books all the time wherever I go. So I read a book during that time. Of course, the hospital was an interesting place at that time because the reception was fast asleep. The security guard who also worked at the Open University in their company is the one who actually told me to go to the particular floor, and he directed me actually. I knew him very well at the Open University. So I was waiting, and then this doctor comes, and then I was sent to the doctor's patient's room, and one of the first thing I noticed was that my first impression was that the doctor was very, very reserved. He was very, very reserved, and there was a sense of energy. There was a sense of energy that he didn't want anyone near him. I felt it very sort of conspicuously, and also I felt it. When I say conspicuously, I felt it in the air and in my being. And then he didn't ask what I meant is a case study. I mean, he didn't ask anything about me. He just looked at it and said, I'm prescribing this, that. And then he said, try not to stress yourself out. Particularly, don't read books when you're not doing anything, just relax. So which was quite a little bit of a shock to me now. Not because I'm a English, I teach English literature and part of my job is to read, not because of anything, because I read all the time anyway and it relaxes me. It's one of the most relaxing things that I do. When I came out, I was very, very distressed in the sense of the reception was still sleeping and I then just went out. Somehow none of the medicine worked for me, and Actually, a student of mine a postgrad student of mine who is a doctor, actually cured me completely without even seeing the condition, without even seeing the patient, in the sense that during COVID, I was teaching, doing some lectures of Peradeniya University via Zoom, and this doctor has not even seen me, and he actually cured me. So that is the first incident. Do you want me to? Yeah. That is my first incident about this doctor. I think because I went there at early in the morning, and universities are very busy. Early in the morning, I perhaps expected some kind of emotional or empathetic bonding with the doctor, and maybe checking out how I relax rather than prescribing me how to relax, maybe because of that. Yeah, my second incident comes once again about when I newly got married, somewhere at the beginning of 2000, somewhere in 2000, my wife had a recurring pain, and my wife, and she went and checked all the internet and books and came to a conclusion what the pain was, and anyway she felt it was in the kidneys. So anyway, we channeled this famous doctor. Once again, I went to the hospital at 3:30 in the morning to get the appointment, and because this doctor was very, very famous, and even at 3:30 I had to wait 1 hour and settle a fisticuff to get an appointment because there were people trying to jump the queue. And so anyway, once we got the appointment, my appointment was number 26, I remember, and private hospital again, and they didn't have a way of informing the patient, which I think they do now, which number is going. So we were there at 5:30, number 26. So the doctor didn't come till about 8:30. So it went on and on. The waiting room corridor was what can I say? It was almost like It was almost like the tunnel that you go through when you die with the light at the end, very dark, it's the sort of described in near-death experience, the famous tunnel, which some people see and some people don't see. So it was like that, and so there was no way for me to read a book, and we couldn't go out because there was a chair. Once you get up to go somewhere, somebody will still check the chair, so we waited. And finally, when the doctor came, when the number came, when we went in, there were the doctor's room, there were 2 chairs. There was another patient on the first chair. We were on the second chair, and there was a nurse examining another patient on the stretcher, and the doctors attending to all 3 patients at the same time, one after the other. And when she was writing something, the nurse would come and say, "Madam, whatever," and then she would rush in there. So the whole thing took about 5 minutes, and of course, the patient was not happy, and I was very confused. Because, and then, that was the second experience, and ultimately that condition was cured by a change in lifestyle and what is called, change in lifestyle and food, which was recommended by me, like Atbehet, in Sri Lanka we call Atbehet. It was completely, the pain vanished due to my own recommendation in food. I'm a freak for health food and of course lifestyle. Yeah, those are the 2 experiences.
Can I ask a question? So have your wife taken medicines prescribed in that second?
She also thank you. She took medicine halfway and stopped it, and then this Atbehet or whatever that I prescribed took over, and the condition was cured. So I think it was. I couldn't read books in the corridor because it was so dark and uncomfortable. So I was standing. I gave the chair and I was standing. I couldn't even read a book because it was dark and we had to watch the nurse's call. So that was the... Yeah, the other experience that I want to talk about is with a state hospital. Yeah, I mean, I'm not saying this because I'm a state sector employee. I love the state sector, but my father had to, when I was in Kandy, I was doing some research at the Peradeniya library. My sister had to rush my father to the Kaluboila hospital. They went to a private hospital and the physician or whoever recommended him to be taken Kaluboila immediately because he has neglected a call so much. My father being my father, he doesn't take medicine and he has neglected it and then he had to be rushed. So it happened in the night. So I came back from Peradeniya in the night. By that time, he was in the hospital. And then in the morning, I went to see him. He had to wait for a long time to get a bed, but he was seated. And when he got a bed, he was sharing a bed with someone. But the doctors were giving very good care. I mean, despite the crowds, despite him having to share a bed, there was very good care given by the doctors there. They were very attentive and like within 3 days he could come home and he took all the medicine and despite the serious fuss made by my father, the doctors and the nursing staff sort of tolerated him and he was totally cured when he came home. And every time I went to see him in the morning with his breakfast, and he particularly wanted the Sinhala newspaper because the newspaper could be shared with all the other patients because they were all waiting to read newspapers. So there were Sinhala newspapers I would take and give him in the morning, though he was used to reading English newspapers. And I was very, very fascinated by the care given there. And second, one of our colleagues in the English department, he was taken to the National Hospital. It's called the National Hospital. National Hospital. Once again, I went to see him in the evening. One of the first thing I noticed was that the ward was very clean. Nobody was sharing beds there. The ward was very clean, and there was a mini library there. People were borrowing books and reading them. And that library, me being a book freak, I went and checked out the library. I mean, the books were all donations. The kind of books that the Sinhala and Tamil books. I didn't know what the Tamil books were, but the Sinhala books were the books that the general public would read, some literary, some modern fiction, and one or two biographies. So I was fascinated by the collection, tiny collection, but it was very good in a glass cage. And the hospital ward was very clean. And my friend was particularly saying that the hospital, the toilets were very clean, he said, which is a very rare comment. And of course, next to me, there was a patient there, a school principal. He was like sleeping, and after the young doctor did the round, and some machine went off. I was concerned. I quickly ran to the doctor and told him. They all came and checked what was happening. So those are I mean, there might be a perception that the state hospitals, the conditions of the state hospitals, I mean, they may be questionable, but this is to just share you that, there could be other perspectives on that same perception as well. Okay, thank you. I think I held on too long.
Thank you very much, Mr. Lal, for sharing your experiences, though bitter experiences as well as good experiences. I am sure the audience would have been reacting, how to react to the situation or the experiences or reflecting. So I will call upon Professor Arosha Dissanayake. So how he is going to reflect on the experiences shared by Mr. Lal.
Right, thank you very much. So I am doing the same thing that you are doing at this moment of time, reflecting on what my very dear friend Lal has been telling you. For Lal is a classmate of mine from DSNI College, and then Lal is not merely an English lecturer, but he has won the very prestigious Gratian Prize for Literature in Sri Lanka in 2012. You won, and he has been nominated further 2 times, so he's one of the top-notch writers. And what we did try to do here is to get an authentic patient experience. Lal is very humble, so no one recognizes him as a celebrity, so he walks into a hospital as just another patient, and that's his experience. So I think reflecting on that and synthesizing, to me, just like Dr. Nalaini said, the first thing is probably to understand who is this man or woman who is there with me. So what Lal very clearly said, that he didn't feel there was empathic or emotional bonding in his first two encounters. Patients are indeed looking for that. If you look at, now it's comically funny to tell Lal Medawattegedara, who is a Gratian Prize winner, not to read. I mean, it belies absurdity. I don't know what to call it. It's complete, so it's comical. Why did that happen? He probably saw Lal reading, and then on his way, the doctor, I sympathize with the doctor. He has come at 4 o'clock in the morning, and Lal felt that he didn't want anybody near him. I also don't want anybody near him at about 5 o'clock in the morning. I also don't want anybody. But the mistake of the doctor was he should not have scheduled appointments to see somebody at that time. Anyway, coming back to Lal's experience, I think the doctor, however good, Lal says that the doctor is competent, he's very good. Was it the security guard who recommended the doctor also? Only they go there. I thought, because that also happens very often, it's the security guard who recommends which doctor somebody must actually see, even in the other. So Lal, what happened was he didn't feel that he was bonding, and the doctor probably didn't spend sufficient time to understand who this man was. And again, you said something beautiful, and now we all know that we must relax. And he prescribed what he felt. He gave a relaxation prescription, which was totally out of tune with the relaxation method that he knew best. So there was that discrepancy, because the doctor, however good, could not perhaps identify who this man was. Actually, now, this was really puzzling. He told me this story, and I just couldn't understand why did this doctor tell him not to read. That sounds so, you can't understand why he said that. I tried really hard. And actually, I think light dawned on me. I went and had a chat with my wife, who is a psychiatrist. Why do you think this doctor said? And he said, isn't it simple? Lal is not like you. He looks so young. And he looks, though we are the same class, he looks so young. And he would have been reading books, and the doctor would have thought he must be studying for some A-levels or some other exam. And, this man must be all the time studying. He would have been studying there. So would have wanted to say, don't stress yourself studying, you relax. Of course, that may have, I don't know, that may have been the way that he perceived that. It is quite possible. But what is important is, again, we come back, who is this man is the question to ask. So I think that 2 minutes to understand who your patient is time well spent. So that is one aspect of it. Second thing is, of course, communication. And as I told you, don't read books. If he had said, if you're studying for an exam, better not to stress yourself. So he assumed, I think the doctor assumed what he was doing. So it's always better not to assume things, because we assume wrong things. We at times assume that the father is actually the husband, or, the son is actually the husband of patients, etc. It's better not to assume some of these things, and actually ask the patient, okay, what do you do? How do you relax? What do you feel about this? So ask rather than imagine that this is how it should be. So that communication aspect of it is very important. First is to understand who this person is, and then to communicate without imagining things wherever possible, asking, what do you think? How do you feel about this? And of course, the third thing is the setting that we see. Now, he has described to us 2 private hospital consultations, government hospital, how the setting is. I think it would be important for us actually to step outside our enclaves and see what is happening outside. How do patients keep themselves occupied till the time comes for them to see you? The mini library type of thing would be very encouraging for somebody who reads. So spent some time, the dark tunnel at the private hospital, which reminded him of actually impending death. So whether there is sufficient. Now I was very impressed the other day when I think Roshan Lianage won the outstation physician award, and he described how he built a spacious, nice waiting area for the patients. I was really impressed by that. So he has paid attention to that aspect which had been neglected in a wealthy private hospital in Colombo. So that setting aspect is indeed very important. One of the good ways to find out how all of this happens is to sit outside as a patient yourself or a carer yourself, and then you see so much that you didn't see. Then of course, seeing 3 patients in one go, it belies imagination again, how that could possibly happen. And the patient would seriously go home thinking that he got the medicine that was meant for the other patient. You can't really stop somebody feeling that way. And I'm not surprised. I'm surprised that your wife took medicine actually for a few days even, because I may have been a bit nervous to take medicine. So, obviously that cannot be done. You might think that in the state hospital, we all do that. Of course we sit somebody here. I will have a patient by my side, and my senior registrar will have another patient by her side. And I might, in interest of time, I might ask somebody to be on the couch and take a history from another patient and then go and examine. But it will not be concurrently. That's what I'm trying to say. It's not concurrently. You will sort this out, write this, and then go there and sort that out. So, obviously, those are, I don't know, that's probably not a very common thing, but those are things that we need to be very mindful and think about. So those are some of my reflection on Lal's story, and I'll hand over to Ganaka, and then when Ganaka finishes, if we have time, you all can and maybe reflect on Lal's story, and then maybe I can also reflect a little more on Lal's story. Thank you.
Okay, now Dr. Ganaka Senaratne, who is the consultant physician at Teaching Hospital Karapitiya, would talk about so many things about compassion.
Good afternoon, everyone. Thank you, Chairperson. So, Mr. Lal explained his personal stories, and Prof. Dissanayake has reflected on it. What I'm going to do is, in next 10 minutes, try and explore this interface under these themes. Well, we discussed few things. Who is a patient for a physician? Who is a physician to a patient? And relationship with the patient. And perhaps a couple of myths prevailing in the practice. And is there a relationship with the professionalism and take-home message? Before we do that, I would invite all of you to pay attention on a video clip taken from a Sinhala teledrama, where a consultation process happening between a traditional medicine practitioner and a patient from a urban area, which might, I believe, give some insight for these areas and questions. Right, here we go. Oh, sorry.
පතාට එකට හින්දල බොනවා. පතාට එකට හින්දල බොනවා.
හොඳ නම් කොහෙන් යන්නේ?
හොඳයි. බුදු සරණයි. මේ මහත්තයෝ අපි කොළඹින් එමු බලන්න. කොළඹට හරියට වහිනවලු නේද මේ දවස්වල?
එහෙමයි.
මහත්තයා බැලලා
නැහැ.
කේන්දරෙම ගෙනහල්ලා තින්න.
කේන්දරයක් නැහැ.
එහෙම. කමන්නේ. වෙනහළු වල පිළිකාවක්.
එහෙමයි.
ඇස්ට්‍රේ කොලාද?
ඒ විතරක් නෙවෙයි වේද මහත්තයෝ. වෛද්‍ය විශේෂඥයෝ හැමෝටම පෙන්නුවා. පිටරටත් අරන් ගියා. ඒ හැමෝම කිව්වා සනීප කරන්න බෑ කියලා.
උන්නැහැට දොස් කියන්න එපා මහත්තයෝ. ඌවා මහ කරුම ලෙඩ. මම උත්සාහ කරලා බලන්න. මාස දෙක තුනක් මෙහි ඉන්න වේවි.
හොඳමයි වේද මහත්තයෝ.
Right. With that video in our mind, let's try to discuss this. So, who is a patient? So, a patient is a person with an illness who is receiving medical care. This is the commonest answer that you get from my medical students when I ask this. But is that all? The word patient comes from a Latin verb called pati, which means to suffer. So, patient is a person who's suffering, obviously. So what are they suffering from? So obvious thing is illness, disease, or pathology. But is that all? I believe they are suffering from many things. Maybe the pain, maybe the anxiety of the dark tunnel and stuff and the times, and social problems, financial problems, so many things to suffer. Not only that, they have ideas, concerns, expectations about their own illness that might play a part in the process of healing. And then they have knowledge and experience related to the illness as well. Coming into fears and anxiety, what are they afraid of? Obviously the illness at times, and maybe the outcome of it. Will I live? Will I lose my part of the limb or something like that? Investigations, blood cultures, blood drawing, lumbar puncture, MRI. So I'm pretty sure they're anxious about that. And system, the hospital is a de novo system for them. So it's very, very controlled place. There are so many controllers in the hospital. Patients have to be abided by their law. And perhaps the staff as well, due to obvious reasons, staff has not been very nice at times for our patients. Coming to the knowledge and experience, do they have any knowledge about their illness? If I tell you a story briefly, there was a lady came into the ward with swollen face, lips, and shortness of breath in the middle of the night and asking her to be given FFP from the house officer. So what would have been the answer from the house officer? He said, look, I can see that you have an allergy. I have never given FFP in my entire life. I will give you some hydrocortisone. But this lady pleaded, no doctor, I need it, otherwise I would die. But it was flatly refused. And she was given hydrocortisone, but later she got herself arrested. This was a 15 years old story. We couldn't do much for that. The disease that this patient was having, C1 stress deficiency, causing hereditary angioedema. So what was the crime committed there? Is it not knowing the disease? No, it's very rare thing. But the crime was not to respect this patient's knowledge and ideas. So, patient is not a person merely with an illness alone. Coming to great Dalai Lama, he said, whether we like it or not, we have all been born into this world as part of one great human family. This journal says a health professional needs to respect his patient. He needs to understand that in front of him, there's a human being who has opinions, points of view, and feelings. So, ladies and gentlemen, patient is not a person merely with an illness alone. Patient is a fellow human being to start with. That's the first thing. And who has all these sufferers, ideas, concerns, and everything. As Chairperson Madam said, Sir William Osler regarded as the father of internal medicine, said that good physicians treat the disease, the great physicians treat patient who has the disease. So perhaps Sir William Osler had the same philosophy in even his era. Right. I would like to ask this question from you. Do you enjoy similarities? In the sense, do you like to meet up our batchmates, friends, classmates? Can I have a hands up from the audience? Would you like to meet your batchmates, friends, and similar people? Yeah, we really cherish that, isn't it? But is there a similarity that we have with our patients? Well, it could be your batchmate, it could be a classmate, it could be a relative, whoever. But if not, still, is there a similarity we have? Yes, the similarity is that we both are fellow human beings. So are we cherishing this unique moment of meeting up with a fellow human being? I do believe this audience cherish that. But this is what literature says. Patients are treated only as carers of disease, and medical attention has shifted from the patient to the abstracted disease carried by them, like in Mr. Lal's case. So care versus treatment. So what is treatment? Treatment is for the illness. People have MI, people have skin disease. That needs a treatment for sure. Balm or local application, or for MI, thrombolysis or something. But what is care? Care is what you do for the entire concept of the patient that we discuss. It's not only illness, a lot of other facets to be addressed. So care is the provision of what is necessary for the health, welfare, maintenance, and protection of someone or something. That's what we need to do as physicians. We need to provide care for care seekers like Mr. Lal and our patients. Coming to the second point, who is a physician to a patient? This is what World Health Forum says in 1996. Surprisingly, few patients seem to worry about the technical competence of the physicians, but they do worry about the ability to understand the patient as a person and provide the right guidance during their journey through the illness. So that's what they need. They want we to guide them through the journey of the illness. Are you a physician in that caliber? I do believe so, but that is what's in the literature. Most physicians are skilled at collecting medical information important for clinical diagnosis. However, they obtain less information about the attitudes, beliefs, concerns, experience the patient has. Without knowing those, physicians may find themselves and their patients frustrated by misunderstanding and having different agendas, like not taking drugs, going to somebody else kind of thing. So for you to guide them, you need to be empathic and compassionate, as we said. So empathy is the ability to understand, share someone else's feelings or experiences by imagining what it would be like to be in that person's situation. So we need to feel what patients feel with them. And compassion is willingness to help. With this mind, you can do a profession in a compassionate way. Coming to the third point, relationship with the patient. So Frontiers in Medicine has said two types of relationships that we can have. One is factual or more formal relationship. The other one is more personal and humane type of relationship. This factual one, physician and the patients are equal partners of a legal contract, which jeopardizes the prioritization of patients' interests. But when it comes to human or more personal type of relationship, physicians adopt an essentialist commitment while respecting the patient's unique concerns. So what do you have to do in the bedside? Perhaps you bring the human-to-human relationship in the first place and then be abided by the doctor and patient relationship. So how do you do that? Maybe accepting, smiling, greeting, trying to help, trying to share, respecting your fellow human being as a friend, and then be abided by doctor-patient relationship, listening to their presenting complaint, and obviously you need to acknowledge their symptom or concern before you technically analyze these symptoms. Obviously the communication is the key for a better patient-physician relationship. One more thing, are patients helpless? Can I have another hands up count, please? Anybody believes that the patients are helpless? No? Very good. Yeah, they are not. But I think that as a society, in our part of the world, it's very common to believe that patients are asarana or they are helpless. But it's not the case. They have so many help arranged by the government. We are paid for that, isn't it? So what has it done? It has made a huge gap between patients and healthcare providers, and maybe it blocks the opportunity for a more humane type of personal relationship with these people. Is there a relationship with professionalism? Yes, the physician charter says medical professionalism is a set of values, behaviors, and relationships that help us maintain the trust with the society. And it demands to prioritize interest of patients above interest of the physicians. So medical professional is a person who prioritizes the patient needs above his or her own. So if we can do that, if we are to do that, we need to understand the whole concept of what a patient is, and we need to be empathic and compassionate. So you can be a true professional. On the shoulders of medicine giants, it says, both science and art, medical practice is the day-by-day application of the treasury of wisdom passed to us by those who have gone before, like ancient Chinese, ancient Hindus, Hippocrates and his commentaries. Maybe the Vedamahatya we have just seen, the traditional medicine practitioner. We should practice what they have innovate and brought to the table. It brings the joy described by Sir William Osler, and it carries the obligation to act with honor and dignity. Coming to the take-home message, ladies and gentlemen. So patient is a fellow human being with an illness who is suffering from many things and facing lots of anxieties, having their own viewpoints and concerns. We need to welcome and accept them with great respect as fellow human beings. Let them feel that you will be right beside and guide them throughout their journey of the illness. Accept the different values and opinions of patients. They have a right to do that. We shall not be judgmental about our peers and previous care received by patients. And instead, you can discuss what you can do and have a common plan. And then, if possible, heartily wish them for their better health. Thank you.
Thank you, Dr. Ganaka, for exploring many ways and how we can incorporate the compassion into the interface between the patient and the physician. Prof. Arosha, you want to comment on anything?
Well, I don't know, maybe it should be the audience which is speaking, but I want to pose two questions to you all, again questions which I am asking myself. Question number one, what is the mechanism that we have or I have to obtain some kind of feedback from my patients about how they feel? I have to work on that. I think you might have to work on that. Second question is, when something does not go right, like has happened in Laos, when treatment doesn't work or something like that, what is the mechanism I have for the patient to approach me again, and rather than going to another doctor and going through the same process, what is the way that he can come back to me when things go wrong? What is the mechanism I have so that he can come back and settle that? So those two things I think I am asking myself, and I think you should ask yourselves also. That will help us become better. And to any one of the speakers or anybody in the audience, I just want to ask you one more question that is not directly related to the practice. We spoke about empathy, we spoke about kindness. Can somebody be empathic and not kind? Can somebody be kind without being empathic? I'm just asking you. Thank you.
Yes, audience. Can anyone be kind without showing empathy, or can anyone be empathetic without showing the kindness?
Arosha, could one be sympathetic and be kind? It's not the same as empathy, but you don't have to understand what the person's worries, fears, pain is. But sympathy is a kind of kindness, but it's a bit patronizing, isn't it?
Yes, sir. I don't know, I personally feel, if you can't really be bothered to be empathic to people, can we at least be just kind to them? We could still be that, right? You don't have to understand how they feel and think. Sir, I don't know. I would value your opinion, sir. Do we have to really understand people's feelings and thoughts? If we can't go through that time due to time pressures, or we just can't be bothered, or we are sleepy at 5 a.m. in the morning, can we just be kind to people and get on with life? Is that possible?
I think this is
sir?
a can of worms, isn't it? You and I could talk, and we have talked for hours about this before at various stages of our career over the last 25 years. But isn't it about Ganaka was talking about human beings. So isn't this a human relationship, the doctor-patient relationship that has been fractured, that has been identified? Because we teach people communication skills, and one of the things that you do with that is the setting must be right. You need to explore the ideas and concerns and expectations of the person. So these are very bland sort of professional skills, but at the heart of it is that they are tools to build a professional relationship. So we have the skills, the same way that we know physiology and pharmacology. We have been taught and trained in communication skills, at least not my generation, but the new generation. So it's how they use those, and aren't they culture specific? You can't use the same sort of skills in Sri Lanka that you would use in a foreign country. So yes, we have the tools, but maybe we are not using them, and maybe we are not managing our time effectively in order to establish that relationship.
Shall we ask Lal to comment as a complete outsider to this?
Yeah, Professor Devaka, the what is called dialectic that you presented, in the sense that what I call it a dialectic is you have opened up, as you said, a can of worms, for which it's very difficult to find what is called boxed answers. So even in my discipline, English literature, or any kind of literature, we have the same issues: kindness, empathy, and sympathy. I think if you read Charles Dickens's Great Expectations, there's this character called Joe. It's a novel worth reading. There's this character called Joe, who is from whose house a convict called Magwitch has stolen a custard pie. And when Magwitch was brought to him by the police, Joe, who is totally uneducated, tells him, "Sir, I don't know how the law is going to deal with you, but since you are a human being and you go hungry, you are always allowed to steal food from my house." Now so even in literature. So then you get novels in Russia where there are characters who completely lack empathy. This concept of empathy, kindness, and sympathy has been explored to a great detail in literature. It is still being explored without boxed answers. We only have examples of people's behavior. So I think that dialectics is on even in the field of what is called textual studies, where I work. So I think potentially each one discovers what empathy, sympathy, and kindness is, and where one ends and the other begins. That's the way I feel.
The Russian literature, which one?
Russian, okay, there's this Fyodor Dostoevsky. He wrote this famous book called Crime and Punishment, and there's a famous character called Rodeo. Rodeo kills a very nasty old woman, and he, without any empathy, the whole novel goes on Rodeo. He lacks complete empathy, and Dostoevsky is one of those Russian novelists who believe in the school of thought that human beings never learn. Now, Arosha says, let us reflect. He believes that does not happen. Human beings, they don't learn. If you're empathetic, you remain empathetic. So that entire huge novel explores this whole idea of rodeo killing someone, and he's lacking empathy until the prostitute with whom he falls in love betrays him, saying that you have to empathize, otherwise our relationship is not going to work. So he's sent to Siberia, and the prostitute moves into another hovel close to the prison to stay with him. So that's the whole story, but there's so many things going on there. Once again, characters who lack empathy. This has been explored even in science fiction, even in modern literature, even in Sri Lankan literature. This has been explored to a great detail, but without any what is called boxed answers.
The mic again, but empathy is the key here. And as a medical educator and as an examiner, my job is to thrust empathy upon people. Some people like Arosha are born empathetic. Some people like me acquire it, but our job as practitioners is to thrust it upon our students and our trainees.
Thank you. Thank you, Professor Devaka, and thank you, Prof Arosha Dissanayake, Dr. Ganaka, and Mr. Lal, for the interesting insight into the compassionate medicine in the exploring the patient and the physician interface. I would like to tell something that as we enter into the medical faculty, we need to achieve 3 A's, but for all of us to become a good doctor, we have to only just achieve 6 C's. So one of that C is the compassion. So just find out what are the other 5 C's. So let me conclude the session with awarding the certificate of appreciation for the speakers. Mr. Lal, Medawattegedara. Prof Arosha Dissanayake.
Thank you very much, everyone.